Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to our medical director, Dr. Brian Wood, to introduce our guest.
Great. Well, a big welcome to Nina Kim. Thank you for coming. Nina is assistant professor here and one of the providers in medicine and one of our co-infection experts who's helped on echo cases before. So I will turn it over to Nina.
Great. Thanks, Brian. Thanks for inviting me to talk to you guys today. He asked me to talk about acute hepatitis C in the HIV-infected context, and I think that's a very timely topic. I'm really happy to be here to talk about this because I don't think it is one that has really garnered that much attention, but it should, especially when I show you some of the more recent data, and I hope that at the end of this talk it will be a little bit more on your radar screens. Today, I'm going to go over some of the recent trends, particularly among HIV-infected MSM, which is not traditionally a population that we consider being vulnerable to acute hepatitis C, but I'll show you why that has clearly emerged, and we'll go over some of the risk factors for acute hep C acquisition in this group particularly. I'll go and show you sort of an illustrative study looking at screening this population, and we'll talk about natural history of acute hep C infection, the clinical features, and then talk a little bit about why it is particularly challenging to diagnose, and then review some considerations as to when you're going to pull the trigger on treatment, and go over why this is sort of a critical decision point, and then review some management issues. So this is the official statistical graph that the CDC puts out of the number of reported cases of acute hep C in the US, and this is through 2000 to 2010. And I just want to point out a couple of things. One is it's clear that the incidence has dropped, particularly in the first part of the decade. And a large part of that is due to, it, in all likelihood, sort of a little more testing, changes in practices among injection drug users, maybe the expansion of needle exchange programs. This is what we like to think. But you can see here that over the latter part of the decade, it's kind of leveled off more or less. In 2010, there were about 800 or so cases reported. But I will caution you that this graph is probably a gross underrepresentation of what's actually happening out there. And that after this talk, you'll realize that most of the cases of acute hep C are actually missed. They don't present to care, and we don't have an opportunity to capture them at that time. And then often what ends up happening is that we diagnose hepatitis C when it's already chronic and established. So hep C transmission, let's go over some of the basics. So as many of you know, hep C is most efficiently transmitted parenterally. It is really most efficiently a blood-borne pathogen. It's several times more infectious than HIV. And sexual transmission in the general population, based on what we know from the literature, is really considered rare. This was an Italian cohort of about 895 heterosexual monogamous couples where there was hep C serodiscordance. One person was positive, another negative. And they were followed out for 10 years. And in this study, only 3 transmissions occurred. And so you could see the incidence rate was like 0.37 per 1,000 person years, so really not common at all. And strain analyses from those 3 transmissions did not support sexual transmission. So the strains were different, suggesting that there was a different source. So intraspousal hep C transmission is really unusual, and it is largely based on this data that the CDC has not really pushed or mandated barrier protection for hep C prevention. I mean, there's certainly other reasons for barrier protection, but if you're looking solely in terms of hep C prevention, there's really not evidence to support doing that in heterosexual monogamous couples. And historically, I mean, when we think about it in terms of HIV-infected population, the things that we know about hep C transmission has been corroborated by the fact that hep C prevalence is really tracked closely with injection drug use. So this was earlier statistics showing that among MSM without IDU, the seroprevalence is about 1 to 7% versus 25 to 50% when you consider MSM with injection drug use. So some of these concepts have really gotten turned on their head a little bit because in recent years what we've observed is a rising incidence of hepatitis C among HIV-infected MSM. And the reports first began around 2004-2005. There were increasing reports of basically epidemics of hepatitis C, acute hepatitis C occurring in multiple countries in Europe, United Kingdom, France, Spain, the Netherlands. There were a lot of cases being reported from the Netherlands of basically outbreaks among MSM cohorts. And then we started seeing these reports emerge in North America, Australia, and Asia. And in the Netherlands, to illustrate, the Hep C prevalence among HIV-infected MSM has risen from 1 to 4% in 2000 to 21% in 2008. Similarly, the Swiss HIV cohort, which is one of the larger European cohorts, they just published this data a few months ago in Clinical Infectious Diseases, which they noted an 18-fold increase in Hep C incidence from 1998 through 2011. And what's also quite striking about some of these reports is that many of these cohorts reported low rates of injection drug use, and phylogenetic comparisons basically showed that the Hep C had transmission clusters among sexual networks of MSM. And what I think has been more alarming, this was actually just reported last year in the retrovirus meeting, is that this is a report from Germany, is that a number of these men who actually acquired acute Hep C and managed to spontaneously clear or get clear on treatment actually got reinfected again, which is reflecting the fact that there's ongoing risk behaviors going on. So this was, they would have 3 to 4 episodes being reported in a single person. So really a clear gap in terms of prevention, intervention at this point. So I wanted to go over sort of our homegrown epidemic, so to speak. This was actually reported a few years ago in the MMWR, just in time for World Hepatitis Day, actually. This was actually a sort of report of sexual transmission of acute Hep C among HIV-infected MSM in New York. And from about 2005 to 2010, they had a total of about 74 HIV-infected MSM who presented to Mount Sinai Medical Center with recently acquired Hep C. And like a lot of the European cohorts, none of them had reported a history of injection drug use. And the phylogenetic analyses showed that these strains had very closely related variants and clustered. They were actually a set of 5 clusters. The clinical features of these men, it turns out their HIV was in pretty good shape. Most of them had CD4 counts that were in the 500 range. Median age was about 39. Most of these men were asymptomatic. It turned out that the new infection was detected solely by ALT elevation that was found accidentally. Only a minority had jaundice, and the median peak ALT was about 600 or so. You could see the range is wide. And so what they did was they did a case control study. So they took these 74 cases, they matched them up with HIV-infected MSM who didn't acquire Hep C, and they asked them to complete a self-administered survey about their sexual practices and drug use behaviors in the 12 months preceding the infection. And a couple of things fell out in the analysis. One was that receptive anal intercourse with no condom and ejaculation of the partner had an adjusted odds ratio of 23 for acquiring Hep C. And then sex while using methamphetamine turned out to be the strongest risk factor associated with Hep C acquisition. And you can see the adjusted odds ratio was about 28.6. So, it sort of begs the question, why is this happening? Why are we seeing these trends? And some of the things that have emerged from the literature is that there are probably 2 factors. One is, there are clear behavioral factors, and as many of you know who take care of this population, there's clearly increased prevalence of serosorting. There's a lot of concordant unprotected anal receptive intercourse occurring among our HIV-infected MSM population, and that there are certain other risk factors that have emerged as putting patients at particular risk for acute Hep C, which is mucosally traumatic sex practices, group sex, use of sex toys, fisting has been identified in the literature as being risks. Use of drugs during sex is a big one, and the one substance that has really stood out has actually been methamphetamine, and this is not intravenous methamphetamine. This is non-IDU methamphetamine. So, and there are clear biologic factors at play as well. There is a particular risk among HIV-infected MSM as opposed to HIV-uninfected MSM, and some of that may be due to the fact that there are higher serum Hep C viral levels in general. As if you're HIV co-infected, that on average you tend to have higher serum viral levels, and there's some data to suggest that there may be more genital shedding of Hep C in that context. And then what has also clearly emerged is that people who show up with sexually transmitted infections, particularly the ulcerative infections like syphilis or LGV, may be at risk for Hep C acquisition. Gonorrhea and chlamydia has also been implicated. So this was actually a study that was it's also homegrown. This is from Rhode Island. This was an urban HIV care center. They are actually quite similar to our clinic here in Madison. About a third of all of their patients was Hep C co-infected. And of these co-infected folks, about just over a third actually reported MSM as really their primary risk factor. 25% did report injection drug use and 2% both. And what they did was they decided to roll out a survey. So they had their patients complete surveys about risk behaviors and perceptions of risk. And they decided to roll out a screening program where they basically did just simple quarterly ALT measurements. And we check toxicity labs on patients who are on heart, but a lot of times we may not always check liver enzymes, and they made a point of making sure that ALT was part of that toxicity screen. And the people they decided to screen were those that were Hep C susceptible and high risk. And their high risk folks, they defined as MSM with unprotected traumatic anal sex, an STI in the last 6 months, and then stimulant or drug use. And then, of course, an MSM with more than 5 sex partners in the prior 6 months also got enrolled in screening, MSM with a Hep C infected partner, and then any intranasal injection drug use. And so anyone who had an elevated ALT, which they defined as greater than 45 or exceeding 1.5 times the baseline, triggered automatically a Hep C RNA testing, which was pooled for those patients that were uninsured for cost purposes. And there were a few things that fell out from their findings. One was on the survey results, it turns out the majority of these men did not perceive traumatic sexual or drug practices increase their risk for Hep C. And not surprisingly, that unprotected sex was often occurring with drug or alcohol use. And it turns out that they had a decent rollout of their screening program. The majority of their participants had at least one ALT in the 9-month follow-up. And they actually picked up a few cases. It was, well, one case among 58 participants. This was a pretty small study. But they put an annual incidence of about 2%. So modest results, but at the same time, I'm hoping to emphasize to you at the end of the talk that it is really important to identify these folks in acute infection. And I think this study points to the fact that we're probably not doing sufficient education towards our patients. It turns out that some of these risk behaviors declined over the course of the year that they were rolling out this program, so clearly some of the messages were getting across to their patients. So let's talk about the natural history of acute infection. The incubation period is actually fairly long. It's about 10 to 14 weeks from exposure to presentation, and generally speaking, clinical illness occurs a mean of 7 weeks from exposure in some studies. The Hep C RNA is really the first test that becomes positive, and it can show up as early as a week post-infection. Hep C antibody seroconversion is detected much later, and it actually can be quite delayed. It can show up as early as 2 months, but it can sometimes take several months post-infection to show up positive. The other thing, as pointed out in the Mount Sinai study, was that only a small minority of patients are actually clinically ill, and rarely is acute hepatitis C a fulminant presentation. So this is quite different from acute hepatitis A or acute hepatitis B, where patients can actually be hospitalized. Their serum ALT, as you see, is lower than what occurs with acute Hep A or B, in the 400 to 1,000 range. Bilirubin is rarely greater than 12. And it's important to remember that spontaneous clearance can occur after acute infection. In the mono-infected population, so in HIV uninfected population, it's estimated to be about 20 to 25%. And it may be slightly lower in those who are HIV infected. So it turns out that diagnosing this infection can be challenging, and I think a large part of the reason why it's challenging is that most cases are asymptomatic and we don't capture them in time. And the other aspect is that we don't actually have a reliable assay that tells us, hey, this is clearly recent infection. So we don't have a specific IgM-based assay, at least a reliable one for Hep C antibody testing. And then you can see here that the CDC case definition is actually somewhat vague. It's acute illness compatible with hepatitis, or a serum ALT that's greater than 400, and you have either antibodies that are positive to Hep C or a presence of Hep C RNA, with exclusion of acute Hep A or B by way of those IgM assays. have to remember that it turns out that Hep C RNA levels can fluctuate pretty widely in early infection. In some reports, it's even been dipped down below the lower limit of detection. Although with our current RNA assays, which are really quite sensitive, our in-house assays, I think the lower limit of detection is about 15, and so really, you're not going to really miss acute Hep C with an RNA assay in most cases now with our current assays. But this is something worth noting. And then, of course, the antibody, as I mentioned, can be delayed. I think most people, about 2/3 of people, are antibody positive by 3 months. But some HIV-infected patients, about 5%, can actually be still antibody negative by 12 months. And this is particularly the case for those who have more advanced disease. So this is just something to note. So this is an illustration of kind of the kinetics of acute hepatitis C with spontaneous clearance, and you can see that in the pink line that the viral level actually peaks quite high and is still quite high during this period, this sort of subclinical period where the patient has not yet presented. So you can imagine sort of the opportunities for infection there, or transmission rather. And that the symptoms really kind of tend to occur during the course in which the viral level is actually heading downwards. And that this is sort of an idealized illustration, but the antibody in blue shows up much later. And this curve can actually be pushed further out here. This is an illustration of acute infection that persists to chronic, and you can see, as I mentioned, there's a lot of fluctuation in the viral level, and the antibody can certainly show up later as well. So, there are clearly, the question of whether to treat or not to treat really hinges in part on how likely you think this person is going to clear their virus. And we actually have some clinical data on that. In HIV-infected patients, it's clear that those with higher CD4 counts are more likely to spontaneously clear. We can actually get a sense of whether someone's going to clear based on what their viral level is doing early on. So someone who has a lower peak Hep C RNA may be more likely to clear. Someone who has a more rapid early decline as well, that's actually a very favorable kinetic profile. Folks who show up really symptomatic, if they're getting to the point where they feel sick, they're having very high viral ALTs, and the presence of jaundice has been shown to be linked with a favorable response and the greater likelihood of spontaneous clearance. There's some demographic factors. Women, on average, tend to clear more often than men. This is another condition where there's an advantage of being a woman. And then younger patients, on average, tend to clear more often than older patients. And then, as with treatment response, we also see variability in terms of spontaneous clearance with respect to the races. And white and Asian patients are more likely, on average, to clear than black patients. This is an interesting phenomenon. If the patient is already a chronic Hep B carrier, it turns out that they are actually more likely to clear their Hep C. And some of this has to do with a phenomenon that we call viral interference. But someone who has active Hep B replication, it turns out that that can prohibit or inhibit hepatitis C replication. And so this is actually a feature. And then, of course, for those of you who don't know, that we do have a genetic polymorphism, IL-28B CC homozygous genotype that is associated with spontaneous clearance. And you can see here that those who have the CC genotype are about twofold more likely to clear. It's important to realize that identifying acute Hep C is really critical, largely because this is our golden opportunity to treat. And we see higher treatment responses when we capture folks in this period. And you can see here that the SVR rates are, on average, more than twofold higher when we're talking about just dual therapy, PEG interferon and ribavirin, in acute Hep C. And these are the percentages that we see in co-infected patients. And we have to decide, the decision about treating someone is important because, we don't want to unnecessarily treat them in those we think are going to clear, but we also want to make sure that we capture them during this window of opportunity and to be able to achieve the highest possible SVR. I'm going to skip the slide, but just to say that it's, we can get some clues just to remind you from the early viral kinetics. If someone's persistently viremic by 12 weeks, chances are pretty good they're going to go on to persistent infection, and we really need to think about treating them. I think most of us agree that there's a short delay of about 12 weeks from presentation is unlikely to compromise our ability to clear the infection with treatment, but a delay of more than 12 months has been shown to have the likelihood of an SVR in someone with recent infection. So timing is really important. We don't really know what the optimal regimen is for acute Hep C because most of the studies that have been done have been case series and small cohorts. In our clinic, we actually treat, and this is co-infected patients with PEG interferon or ribavirin for 24 weeks. And we reserve the longer treatment for those who are motivated and who don't have really a great initial viral response. The last slide, just, I was sort of anticipating a question about how direct-acting antivirals might have a role here. I think it remains to be seen. It's worth noting that there really is no clinical data on telaprevir and boceprevir. And I think part of this is because we tend to see pretty high SVR rates without it. And so I don't think there's a whole lot of motivation to adding on additional drugs, but it is clear that these drugs are going to revolutionize Hep C management in both acute and chronic infection, and that there is a real potential for all oral, interferon-free regimens, and who knows, we may get to a point where we're treating acute Hep C in less than 12 weeks with these combinations of antivirals. So do stay tuned. I'm going to leave this as my last slide. This is a web-based tutorial that David Spock and I have that you guys can access this, get free continuing education credits. There's some case-based modules there, glossary. You can download slides. So I just wanted to put a small plug in for that and to thank you guys for your attention.